Good morning, students of the International Medical Faculty, third year, first division. Let us start our first lecture on pharmacology. So, you studied in our department for 2 weeks, and you, of course, discussed with teachers about pharmacology, but a few words. What is pharmacology? First of all, translation of this term, pharmacology, from two words, pharmakon in Greek, the drug, medicine, remedy, and logos in Greek, science. So, translation of this term is science about the drugs, But nowadays, this science is too large, and includes separate pharmacological studies. We distinguish, first of all, pharmaceutics. Pharmaceutics is the large complex of disciplines which is directed for study of ways of production, storage, and distribution of drugs. And within pharmaceutics, there are separate disciplines concerning the drugs. Pharmaceutical chemistry, which studies chemical structures and properties of drug substances. Pharmacognosy, which studies the raw materials of plant origin mostly used for obtaining of drugs. There is separate study, technology of drugs, biopharmaceutics, and so on. But pharmacology itself is really science about drugs, but studies interaction between the drug and the organism. Exactly this interaction between the drug and the organism. What is human organism? You studied for 2 years in anatomy, histology, biochemistry, physiology, and so on. But what is the drug? You will study in our department. First of all, what is the drug or medicine? This is one or several chemical substances produced in special drug form and used for treatment or prophylaxis of the disease. What are the basic sources for drug obtaining? First of all, there are natural drugs and synthetic, of course. From nature, we can obtain drugs from plants for thousands of years, of course. From tissues and organs of animals and human beings, for example, from urine, placenta of human beings. Third, mineral substances, natural mineral substances. Synthetic drugs are synthesized in chemical laboratories, pharmaceutical laboratories, and synthetic drugs can be analogs of natural molecules, but can be different molecules absent in nature. Besides these sources, nowadays, we produce drugs by genetic engineering methods. After, we produce the drugs producing antibodies. Sometimes antibody interacts with special molecules, but sometimes antibody is a carrier of substance, helping to deliver drug substance exactly to the cell. So these are basic sources of drugs obtaining. Again, pharmacology. Pharmacology is the science about interaction of the drug and the organism. First of all, we use the drug to cause specific changes in the organism, positive changes. So the drug, of course, changes organism functions. It's action of the drug on organism. But the drug itself is changed within the organism, passing through several processes. First of all, the drug is absorbed, after is transported in blood, after is distributed, after it is biotransformed, and after excreted. All these processes are very, very important. We should understand both, and the drug action influence on the organism, and also processes happening to the drug in the organism. Of greatest importance, both. So, changes developing in an organism under the action of a drug are described by part of pharmacology with the name pharmacodynamics. So pharmacodynamics studies and describes the action of the drug. The action means changes of function of an organism in the whole of the systems of certain organs, tissues and cells. This is pharmacodynamics. And processes happening to the drug and change of drug molecule structure within the organism are studied and described by pharmacokinetics. Pharmacodynamics and pharmacokinetics are both of greatest importance. Of course, you hear the term clinical pharmacology. What is the difference between pharmacology and clinical? Of course, it is pharmacology. But clinical pharmacology, we mean that this is usage of drugs exactly in patients. Because before usage in clinic, we use the drug in animals. Any new drug should pass first preclinical trials on animals. In cats, in rabbits, in dogs, in mouses, and so on. And usage in animals, this is pharmacology. Clinical pharmacology is concerned usage of the drugs in patients. Nowadays, there are thousands of different drugs in different countries. But besides real drugs, we have also special preparations which are called supplements, or biological supplements, or food supplements. And there is very, very big difference between a real drug and supplement. Every drug passes through several years, 6 to 14 years of different trials. During these phases or stages, these drugs are thoroughly studied. After all stages, we know about the drugs almost everything, and we are sure that this drug is effective and, of course, not so toxic. We are sure that the drug can cure to the patients. Supplements don't pass these phases. It's first, and supplements don't have special pharmaceutical documents. That is why it's nonsense to compare action of supplement and action of the drug, or usage of supplement and usage of the drug. And of course, the doctor always should recommend the drugs which have passed all stages of investigations on quality of drugs, but in details. First stage lasting approximately 1 year includes coordination of healthcare needs and research directions of scientists. For example, it's very interesting, very important for us, for doctors, to have maybe newer and more effective drugs against certain diseases, for example, tuberculosis. And we ask scientists, chemists, please work to produce, to discover new anti-tuberculosis drug. And this investigation includes empirical search, modification of chemical structure, targeted synthesis, combining of drugs, and if new substance, we are not able to call it first drug substance, but if this substance is interesting, we think that maybe this substance can become a real drug, we call it pharmaceutical substance. And this pharmaceutical or physiologically active substance is very interesting. It's necessary to pass the second stage. The second stage includes pharmacological studies and pharmaceutical studies. Pharmacological studies include pharmacological screening. Definition of LD50. LD50 is dosis letalis. Dosis letalis means the dose causing the death in 50% of animals. This index shows us approximately toxicity of the drug. If toxicity is high, of course we will not continue study of this agent. If toxicity is not high, we will continue. And at the same time, the drug has specific influence on the organism. And of course, identifying of the structure-action relationship. So if substance is interesting for further investigation, we should know, of course, physical and chemical properties. So pharmaceutical studies includes primary study of physical and chemical properties, and also it's necessary to have essential amount of substance for further investigation. So production of the required amount of the substance for further research. Third stage, preclinical study of pharmacologically active substance and pharmacological preparation. I told you in the beginning that the drug or pharmacological preparation is one or several drug substances produced in special drug form. For animals, we can not to use special drug forms. But if this agent in animals shows us interesting effects and low toxicity, and we understand that can be after clinical trials, of course we should investigate this chemical substance thoroughly and produce a specific drug form, specific drug form. So you see that third stage preclinical study includes pharmacological studies and pharmaceutical studies. So pharmaceutical studies is working out of a drug form, working out of pharmacopoeial monograph project, or description of physicochemical properties. Description of the physicochemical properties. No one supplement doesn't have this this pharmacopoeial monograph, and we can't control supplements, but we can and we control any drug, because any drug has pharmacopoeial monograph. But before pharmaceutical studies, pharmacological study includes its study of specific actions. Specific action. For example, one chemical substance causes hypotensive activity, so we study exactly hypotensive. Another, for example, bronchodilating, so we should study this activity. But within specific actions, we study ED50, effective dose 50, LD50, doses letalis, those causing the death in 50% of animals. This dose causes activity, positive effect in 50%, and shows us principal activity of the drug. After, we perform comparison with standard preparation. We have the drugs, for example, for treatment of tuberculosis. We have nowadays. For what do we need new drug? If this new drug will be better, stronger, less toxic, but we should to compare this new agent which is studied with standard preparation. And of course we should study on animals, but on adequate models. It's not interesting, for example, to study hypotensive activity in normal animals. The drug should act in condition of arterial hypertension. So we should model in animals first arterial hypertension, after investigate the drug. And besides this, we also study pharmacokinetics. How the drug is absorbed, distributed, biotransformed, excreted. For example, if the drug is not absorbed in intestine, we never produce it in the form of tablets. We will use in the form of injections, for example, and so on. And if after these pharmacological and pharmaceutical studies we understand that this is interesting perspective agent and maybe it can be used as the drug, so we recommend it for clinical trials. So next stage. But clinical trials include several phases. Clinical trials means study of the drug substance, or more precisely pharmacological substance, in human beings. But you see, first phase is non-therapeutic study. Non-therapeutic. Why? Because we study not in patients, but in normal people, in healthy volunteers. This is first stage, non-therapeutic clinical study. So 80 to 100 individuals participate, and this study lasts also approximately till 1 year. The purpose of this first stage is to find out whether it is worth continuing to work on a new drug. If so, then set the dose for the study in the second phase. Basic tasks: obtaining preliminary data on the safety of the drug, the first description of pharmacodynamics and pharmacokinetics of the drug. First, we examine one introduction, one dose, after multiple introduction, like in real practice, because course of treatment of the patient, of course, lasts 7 days, 20 days, 12 days, certain amount of days. And we study first one introduction and after several introductions. After, if we see that this agent is not toxic in patient and has certain effects, so the agent is interesting, we recommend continuation of clinical trial during second phase. But second phase includes two substages, 2A, 2B. 2A, pilot, preliminary clinical trials, 2B, pivotal, basic or wide. During second stage, 200 to 600 patients with a disease or syndrome for treatment of which this drug is being developed participate during this study, unlike during first stage. Once again, first stage, healthy volunteers, and second phase, exactly patients with certain disease. So, pilot trials, the purpose is determination of the safety level of the drug in selected groups of patients. Pivotal or basic clinical trials phase has the purpose to determine both and safety and efficacy of drugs in patients with the corresponding disease. The main task of the second stage is determining the optimal level of dosage of drugs to continue the study during the third phase. The first phase, this is the basic phase for clinical trials. We call it thoroughly monitored, extended studies designed to be close to real conditions of use of the drugs. Thousands of patients participate, thousands. If over 10,000, we call mega clinical trials, mega. And the influence of concomitant diseases, age, drug interaction is studied, the placebo method is studied, of course, comparison is made with groups receiving other traditional treatment. The purpose of this third phase, obtaining data on safety, efficacy of drugs for assessing the benefit risk indicator and preparing to obtain permission for the drug official use. After third phase, the drug can be recommended to official use. If it is recommended, it becomes the drug preparation, the drug. Before it was pharmacological preparation, after recommendation, permission of special organ. In our country, in Russia, this is special pharmacologic committee in Ministry of Health of our country. So third phase is over and we can start usage of the drug in the hospitals. And before this, of course, it it's allowed to start production of the drug. Before this, no one pharmaceutical plant or factory should produce these agents. Only after clinical trials, after permission of special pharmacological committee. In different countries there are analogs of this organ, for example in USA FDA, Food and Drug Administration, and so on, and so on. But after we have started to use the drug in patients, this drug continued to pass clinical trials, the fourth phase. So it is carried out after obtaining permission to use the drug in parallel with its use in the clinic. Purposes. We want to know more and more exactly about these drugs. Improvement of drug dosage regimen. The study of different duration of treatment courses. Interaction with food, other medicines. Comparative analysis with other standard courses of treatment. Study of pharmacoeconomic indicators. Study of long-term effects, mortality rates. It's very, very important because some negative effects appear in a few years, and within primary clinical trials we are not able to investigate it. But in several years we can see that there are negative effects. And if we investigate and discover this, we are able to stop usage of the drug. So after third phase, or we continue to use the drug, but we know about this agent a lot of different things, or we can stop usage if we have revealed negative properties. So you see, real drugs really should pass all these stages and phases, and preclinical and clinical, and for real drugs, processed materials about documentation, analytical, chemical documentation, pharmaceutical documentation. But no one supplement has these documents and passed these trials. Okay. Now we should discuss the names of the drug preparations. Names. We distinguish INN or international non-proprietary name, brand name, and generic name, So one and the same substance can have several names. What does it mean? First of all, INN or international non-proprietary name is the name of active substance of this drug preparation, active substance. This name is common for the whole world community. It is assigned by a special international commission on the nomenclature of drugs. INN. One and the same INN for this substance in all countries and for forever. After brand name. Brand or original drug is a drug that contains an active ingredient that was first developed and has no analogs. Of course, brand name, this is the name of preparation with INN. This drug brand is a discovery. The brand name is assigned by the company that first developed this product. And no one company, pharmaceutical plant, is able to name produced drugs with this name. Only company that first developed this product. Generic names, generics. Generic is a copy of the original drug. After pharmaceutical company first produced the drug and called it with brand name, only this company is able to produce and widespread this drug. And all patients of the whole world can use only this brand preparation, original drug, for several years. After 5-10 years, all of pharmaceutical plants can start production of copy of this original drug, and they start to produce, but they give to this drug their own name, and this is generic name. So generic names are assigned by the companies that reproduced the copy of the original drug. So branded drug is original, but there can be many of generics, but all of generics include one and the same substance with certain ANN, but have different names. Let's continue. In the beginning of the lecture, I told you that pharmacology includes two parts, pharmacokinetics and pharmacodynamics. So pharmacokinetics studies following processes happened with the drug within the organism. First of all, the drug should be introduced by special route or method. So introduction. After, the drug should be absorbed into the blood. Absorption of the drug from external environment into the blood. After, transport or transportation with blood. Transportation. In what form the drug is transported. And distribution. How is the drug distributed in different tissues and organs, equally, non-equally? Biotransformation within the organism. Any drug molecules is biotransformed into another, more often inactive, sometimes less active, and rarely a little more active substances. So primary molecule is changed. It is called biotransformation. And after excretion through different organs, it's necessary to know through what organ. For example, if the drug is excreted through kidneys, but a patient has kidney disease, it's better not to use this drug. It's necessary to take into account. So introduction, absorption, transport, distribution, biotransformation, excretion are processes described by pharmacokinetics. short break for several minutes. let us continue our lecture. Let us continue our lecture. So, first of all, let us discuss a little roots of drug introduction. We distinguish enteral and parenteral. Enteron in Greek means intestine. That's why enteral, its introduction via the digestive channel. Parenteral, escaping the digestive channel. Via digestive channel, we use oral introduction, or per os, abbreviation PO, oral per os. It means it's necessary to swallow the drug, to swallow, sublingual. A patient should put the drug sublingually and suck it. Transbuccal, under the cheek, and to suck this tablet, for example. Intraduodenal, with the help of probe, we can introduce the drug exactly in duodenum. This is rare route. And rectal, introduction per rectum, in rectum. These are enteral. Parenteral routes include injections with the help of syringes, inhalation, introduction through airways, and introduction through the skin. Can be application of different forms, ointments, solutions, and so on. And second, with the help of electrophoresis or phonophoresis. We can use all of these routes, of course, but more often among enteral we use oral, and among parenteral we use injectional. Short comparison of these two. Oral, injectional, used more often. Oral is the simplest route of introduction. For oral route, a patient needs only the drug, nothing more, and water, of course, nothing more. It's very good. But for injectional route, for injections, a patient should have injectional form of the drug, syringe. If a patient has the drug but there is no syringe, so injection is impossible. And of course, the nurse, special personnel, especially if these are intravenous, intraarterial injections, it's necessary to have, of course, special nurse. It's not comfortable always. But from other side, injectional route is very exact. You see, injections can be intravenous, subcutaneous, intramuscular, and so on. If we introduce exactly in blood, so 100% of the drug there is in blood. 100%. Very exactly. We know exactly the dose. The dose is amount introduced to the patient. If this is oral introduction, of course we know the dose which is taken. But which portion of this dose is absorbed into the blood, we don't know. This portion can be different. That is why we should be very exact using oral introduction. when we recommend to the patient oral introduction, we should control this process thoroughly. And we should understand that oral more often is used in outpatients, injectional more often is used in inpatients. So, why don't we know exactly what portion of the drug is absorbed into the blood after oral taking? First of all, because the drug interacts with food. But a patient can take more food or less food, and patient can take different kind of food. Because of this interaction is different. That is why absorption is not equal all time. It's first. Second, we should be sure that condition of mucosa of stomach, duodenum, intestinal is normal, because absorption is function of epithelial cells. In any inflammation, of course, absorption is changed, and we are not sure that the drug is absorbed completely. So, first of all, it's necessary to be sure that absorption is normal. It's second. Third, of course, absorption depends on interaction of drugs, because we rarely use only one drug alone. More often, we administer 3-4 drugs, and these drugs can interact within digestive channel. For example, can be direct interaction, physical, chemical, can be interaction because of influence on peristalsis. If the drug activates peristalsis, so absorption of other drug is decreased. And on the contrary, if the drug slows down the peristalsis, so absorption of other drugs is activated. It's very important to be very attentive in administration of drugs for oral introduction. After is very important, very important. How to use the drug? Before meals, after meals. For some substances, it's not important, and we can use independently and before and after. But for some substances, it's of greatest importance to use, to take exactly or before meals or exactly after meals. Why? Let us discuss about mechanisms of drug absorption. There are several mechanisms of absorption. We should understand that drug molecules can be absorbed via cell membrane of epithelial cell, and can be absorbed through the pores in between cells, through the pores. Comparison of total area of membranes with total area of pores shows us that area of membranes is much more, of course. That's why transportation through membranes is basic. So drug molecules are better absorbed if they are absorbed through membrane. So first mechanism, passive diffusion. This is transport through cell membrane. Is realized according to concentration gradient. From the zone with high concentration to the zone to low concentration. Without energy consumption. Exactly liposoluble or lipid soluble, which are in polar molecules, are transferred. Why lipid soluble? Because basic component of any cell membrane is phospholipids. To pass through phospholipids, it's necessary to be lipid soluble. But lipid soluble molecules are inpolar, non-ionized. Non-ionized. It's first mechanism. Second mechanism, simplified diffusion. This is also transportation through membrane, through phospholipids, but with the help of special transport system. Not taking energy, so without energy consumption. Transport system helps a little to transport drug molecule through cell membrane. But we see that this mechanism requires special transport protein. Third mechanism, active transport. This is also a mechanism of transportation through cell membrane. The drug is transported with the help of transport system. But this transport system takes ATP, takes energy for this transportation. That is why different molecules can be transported different. And lipid soluble and water soluble because of taking of energy of ATP. And we should understand that this protein transport system by the function is enzyme ATPase. So this transport system or ATPase cleaves ATP, takes energy and transports drug molecule through cell membrane. And it's possible to transport by this mechanism from the zone with lower concentration to the zone of higher concentration. This is mechanism of transport through cell membrane also, but it requires a very special transport system. So we see three mechanisms: passive diffusion, simplified diffusion, and active transport. This is transport through membranes. One more, pinocytosis. Pinocytosis is mechanism of transportation also through cell membrane, but is very specific. First, invagination of cell membrane, after formation of transport vesicle, transport of drug with vesicle, and after exocytosis. But this is also transport through cell membrane. So there are four mechanisms of transportation through cell membrane. Four. And fifth mechanism is filtration. This is transport through pores in between cells. Through pores. If through pores, so water soluble or hydrophilic molecules can penetrate, and this mechanism is realized according to hydrostatic pressure gradient, and doesn't depend on concentration. Without energy consumption, without energy consumption. So we see one mechanism of transportation through pores and 4 mechanism transportation through membranes. That is why we understand that water-soluble molecules transported through pores are absorbed less than lipid-soluble transported through membranes. And among 4 mechanisms, passive diffusion, simplified diffusion, active transport, and pinocytosis, of greatest importance, the most widespread, is passive diffusion. Passive diffusion. This is transport through cell membrane according to gradient of concentration. That is why we should understand that in GIT, and not only in GIT, transport through cells depends on chemical structure of molecule. Lipid-soluble molecules are always better absorbed through membranes, lipid-soluble molecules, than water-soluble. But lipid-soluble, once again, is neutral, non-polar, polar molecule, and water-soluble is polar or ionized. But we understand that any substance in digestive juice after taken is ionized because of laws of electrolytic dissociation. And this dissociation or ionization depends on pH. On pH of the drug and pH of gastric juice, intestinal juice. First of all, gastric juice. We understand that gastric juice is always acidic. During meals, most acidic. In between meals, least acidic, but acidic. That is why, independently after meal or before meal, the drug after oral taking passes through stomach with more or less acidic environment. Electrolytic dissociation depends on pH. So, same pH prevents dissociation. Opposite pH promotes dissociation. So, if the drug molecule is a weak base being in stomach, it is dissociated. But dissociation increases polarity of molecule and inhibits absorption. So we can think that no need to use orally basic compounds. It's not correct. We can use basic compounds, but we can use these compounds during least acidity. In least acidity, dissociation is decreased. That is why if compound is basic, it's necessary to use before meal. On the contrary, acidic compound, acidic drug is less dissociated during highest pH and more dissociated during lower pH. That is why if the drug is acidic, it's necessary to use it during highest acidity period. It means just after meals, if we need the drug to be absorbed. So, it's very important, if it is written in instruction to the drug, that the drug should be introduced 30 minutes before meals. It's very important, we recommend to the patient, or after meals. It's very important because this helps us to control further absorption and appearance of certain concentration of blood, because we understand that pharmacological effects or influence on organs and system depends on, first of all, of concentration in blood or blood plasma. But for this, the drug should be absorbed. So, we must understand that better absorbed the drugs which are lipid soluble. Less absorbed the drugs which are water soluble. There are such indexes of absorption, bioavailability and bioequivalence. Bioavailability is index of absorption. It shows us what portion of the drug dose is absorbed into systemic circulation. This is the ratio of the portion which is absorbed to systemic circulation to total introduced dose. The introduced dose is 100%, but for example only 40% absorbed to systemic circulation. It means that bioavailability is 40%. 40%. It's very important index, so we can think that it's necessary to use only the drugs with high bioavailability. If we compare two drugs and bioavailability of first drug is more than of second, it's better to use for oral introduction first drug. It's correct. But sometimes we use orally the drug with low bioavailability if we don't need the drug to be absorbed. For example, if we need influence on mucosa of stomach, intestine, or, for example, on microorganisms within stomach, intestine. If we need exactly this, the drug should stay in lumen of digestive channel and no need the drug to be absorbed. In this situation, it's better to use the drugs with lower bioavailability. We understand that if we introduce the drug intravenously, so 100% of drug substance is introduced in blood. It means bioavailability of the drug in intravenous introduction is 100%. In different injections, almost 100. That is why we discussed that injectional routes are more exact. We introduce the drug and we know how much of drug substance there is in the blood. Bioequivalence or pharmacokinetic equivalence. It is the degree of similarity of a pharmaceutically equivalent drug to a reference drug, usually a generic to original patented drug or brand. We discussed that first the drug is produced only by special pharmaceutical plant. It is the brand preparation, but brands as a rule are very costly. After several years, when different plants can produce copies of brand preparation, they start to produce this copy, and they also want to sell these products. But it's possible only if they can prove that their copy is equivalent to the brand. And first of all, we study comparison of bioavailability. Bioavailability of the brand and of generic. If bioavailability is the same or very close, we understand that this generic is bioequivalent to brand. Bioequivalent. If bioequivalent, it's possible to use, because action will be same or almost same. But as a rule, generic preparations are much cheaper. But first of all, it's necessary to prove that this generic is bioequivalent to brand. Bioequivalent to brand. It's possible to study bioequivalency, for example, to compare bioavailability of different drug forms. One and the same substance, but in the form of tablet, for example, or powder or solution. As a rule, in the form of solution, the drug is absorbed better. Second place, powder, and third place, tablet. If there is not serious difference, we can produce the drug in the form of tablets. It's very convenient for pharmaceutical plant and for patients, tablets. But if there is serious difference between, for example, of absorption of solution and tablet, we will recommend to use the drug in the form of solution, of course. But this comparison shows us bioequivalency. Transport in blood. So, after absorption by different mechanisms, the drug is transported in blood. But it is transported in two fractions, in two forms. We distinguish free fraction. These are drug molecules dissolved in blood plasma. Pure drug molecules in blood plasma. Amount of free fraction, amount of free molecules ensures rate of effect development and its intensity. The more free fraction, the higher rate or beginning of effect, and the more intensive, the stronger effect, the more free fraction. And second, bound fraction. Bound fraction means drug molecules connected to plasma proteins. They are transported with connection with plasma proteins, mostly albumins. Sometimes blood cells also transport this fraction, bound fraction. So, this fraction ensures action time and cumulative properties. The more this fraction, bound fraction, the longer effect, but more often this drug can cumulate. If cumulated means concentration is increased, so this drug can cause poisoning. It's necessary to be very attentive using the drugs with high bound fraction. This ratio, free fraction to bound fraction, is constant for every drug substance because it depends on chemical structure. But it also depends on amount of proteins That is why this ratio can be changed in hypoproteinemia. In hypoproteinemia, free fraction is increased because not enough of proteins. But in increase of free fraction, action is increased. That's why it's very important to control amount of proteins in blood in every patient. And if we use two drugs but with different ratio, it's necessary to be also very attentive, because if the drug has high affinity to proteins, high bound fraction, so that leads to decrease of bound fraction of another second drug which has lower affinity. That leads to increase of free fraction of this drug. That leads to intoxication of the patient. We use ordinary dose of first drug, ordinary dose of second, but at the same time we investigate intoxication, toxic effects of the drug because of interaction, because of different affinity to drug molecules. It's very important to pay attention on this ratio every time when we administer different drugs. The main fractions of the drug in the organism. So drug preparation is absorbed into blood plasma, and there is free fraction and bound fraction. Free fraction acts but also metabolized, but bound fraction doesn't act but give molecules to free fraction. Because the drug is metabolized and excreted, free fraction is decreased, and molecules to normalize concentration of drug passes from bound fraction. Distribution of the drug. First of all, we should understand that distribution may be homogeneous and non-homogeneous. Some drugs are distributed equally in different tissues, but more often drugs distributed differently in different tissues. There is special index for distribution, volume of distribution, apparent volume of distribution. It is the ratio of the amount of a drug in the body or dose to the concentration of a drug in blood plasma. If concentration in plasma is high, it means the drug is worse distributed in different tissues. If concentration in blood is low, it means the drug is distributed in tissues. So if the drug is not distributed in tissues and concentrated in blood plasma, this index will be low. On the contrary, if volume of distribution is high, it means the drug is distributed in organs and tissues. Distribution of the drugs in the tissues and organs depends on following. First of all, the level of vascularization of tissue. The more tissue is vascularized, the more drugs is in this tissue. For example, if we compare if we compare the consumption of drug substance in bone tissue, for example, and in liver or in thyroid. Both thyroid and liver are well vascularized, but bone tissue is lower vascularized. Total amount of drug in these tissues is different. Of course, lower amount of drug in the bone. But if we compare concentration of the drug in the capillary independently of bone, of liver, of kidney, so concentration in capillaries is the same, but amount of capillaries is different. The more capillaries, the more vessels, the more blood in the organ. That's why the more drug substance in this organ. Second, affinity of the drug molecule to the tissue proteins. If the drug penetrated into the organ and there is special protein to which this drug is bound, so the drug is accumulated in this organ, And the third, the structure of histohemetic barrier. Histohemetic barrier. We distinguish ordinary histohemetic barriers and several special. Among special, there are hematoencephalic, placental, hematotesticular, and so on. More often we take into account hematoencephalic and placental barrier. Hematoencephalic means barrier between blood and neurocytes in the brain and spinal cord. Via this barrier, the drug substances penetrate less. Same through placenta. So, content of agents in blood of mother and in blood of fetus is very different, because this barrier is not penetrated for different drugs. Why? You see the scheme. This is ordinary capillary, cross-cut of ordinary capillary, and cross-cut of brain vessel, brain capillary. You see ordinary capillary. So there are pores. Да, что такое? In between endothelial sites, but in brain capillary there are no pores because of very tight connection. So we understand that molecules which penetrate by the mechanism filtration in ordinary capillary penetrate from capillary to tissue, but in the brain don't penetrate. Substances which are filtrated are not penetrated to brain cells. It's first. And brain capillaries, this is neurocyte, and in between neurocyte and brain capillary there are glial cells which form specific layer for additional filtration. That's why some molecules are not filtrated to neurocytes. That is why to neurons some drug molecules can't penetrate. Biotransformation of the drugs. Biotransformation or change of chemical structure. First of all, why primary molecule of drug substance is changed? The answer is because of action of enzymes, of our enzymes. So this process is enzymatic because enzymes promote chemical reactions. These are reactions of change of chemical structure. That is why after introduction in the organism, any drug can be biotransformed, changed. because there are enzymes in saliva, in gastric juice, in blood, in different organs, different cells. There are a lot of different enzymes. And principally, the place of metabolism can be very different. The drug can be metabolized everywhere, but we understand that there are specific organs with more active enzymes. For example, liver, lungs, and metabolism of any molecules, including drug molecules, in these organs is higher. But the most specific organ of drug metabolism is liver. Most of drugs are metabolized in liver by hepatic enzymes. It's first. Second, what happened to the drug? What is the purpose of metabolism? For what the agents are metabolized? The purposes of metabolism are: first, decrease of toxicity of primary molecule, and second, activation of excretion of drug molecule out of the organism, from the organism. Next, as a rule, the drugs are metabolized via two stages. This is drug substance. So first stage of drug metabolism is called metabolic biotransformation or non-synthetic reactions. These are reactions of oxidation, reduction, and hydrolysis of primary molecule. There is no new synthesis. That's why non-synthetic reaction. So primary molecule is or oxidized or reduced or hydrolyzed. It's first phase, non-synthetic. After this metabolite passes the second stage, which is called conjugation, because of conjugation of metabolite of the drug with endogenous metabolites, glucuronic acid, sulfuric acid, amino acids, methyl, acetyl, and this conjugation comes to appearance of new substances. That is why conjugation is called synthetic reactions. So all reactions of formation of conjugates are called synthetic reactions. And because of these two stages, the drug becomes more hydrophilic. That is why excreted faster from the organism. Sometimes the drug is metabolized via first phase only. Sometimes via second. This is only one phase, but sometimes the drug is metabolized only via conjugation. Sometimes. And as a rule, metabolites of the drug substances are less active. As a rule, very rarely drug metabolites are more active. These drugs are toxic. And sometimes primary molecules are not active, but they are activated because of reactions of metabolism. So primary molecule is not active, but it is activated because of metabolism and becomes active and acts. We call such drugs prodrugs. Prodrugs. And we understand if this is prodrug, so the action is not so fast. Because for beginning of action, essential is period of activation during metabolic reaction. During metabolic reaction. We understand that basic organ of metabolism is liver. That is why in liver diseases metabolism is delayed. That is why concentration of the drug substances in blood can be increased. That is why that can cause intoxication. That is why in liver disease we should use the dose a little less than in ordinary patients. For today we will finish our discussion. Goodbye. I will wait you for new lecture.